It's a Northwest Lifestyle Weekend on KOMO News. IRG's Health Talk continues.
Our first guest today, Dr. Alison Putnam from Providence Medical Group, the Everett Physiatry Board, certified in American Board of Physical Medicine and Rehab. Iliotibial band syndrome. This is, if I'm not mistaken, this is what you use that roller for, right?
Oh, wow, Tom. That's amazing. You have been listening.
That is great.
I've been you're going to get some kind of diploma on in the mail some of these days, yeah.
All right, we're going to talk with Dr. Putnam and find out a little bit more about IB syndrome with Shannon O'Kelly.
Dr. Putnam, thank you for joining us and welcome. How are you today?
I'm doing great.
Well, again, thank you for coming down. You're a sports medicine physician. You're practicing in Everett. Tell us about your practice. Tell us about your interest in your practice and the type of patients you see and why you enjoy it so much.
So I am in a physiatry practice in Everett. We typically see patients with musculoskeletal conditions, back pain, neck pain, other spine-related conditions. I enjoy doing that. I like improving people's function, getting them to where they want to be with their goals in mind.
Tell our listeners about your fellowship. You actually have a fellowship in sports medicine. Maybe talk about that training aspect.
Yeah, so I spent a year at the University of Colorado doing a sports and spine fellowship. So I did sports coverage for multiple sports teams in the area, Denver University, University of Colorado. And then I also did interventional spine training, so training to do different spine-related injections for pain.
Is there any area of your practice you particularly enjoy, or do you like it all, or do you have a little area that you really like to work in?
I tend to like it all, though I am the only person in my practice who does spine injections, so I really enjoy having that niche.
Okay, we're going to talk about iliotibial band syndrome, or otherwise known as runner syndrome. So maybe we can set that up anatomically. So maybe describe what's going on from a musculoskeletal standpoint for our listeners there.
So the iliotibial band is a tract of soft tissue that runs from your buttock region down to the outside of your knee. Oftentimes it causes pain at the outside of the knee. It's the most common cause of knee pain in runners. What happens, we think, is that when you don't have good strength around your core, that you develop tension or even friction around the bones and soft tissue of the knee, which can lead to pain.
It's interesting because anatomically, the way that tissue runs, it's a fibrous connective tissue that comes off muscles in your hip and runs down and attaches in a bony area on the lateral or outside of your knee. And there's a bone right there, the condyle, that forms a little bump on the outside. And the theory is that tissue's tight, it's going to irritate, and that tissue becomes inflamed from overuse and kind of chronic use.
Exactly. So not only is it tight, but when people have decreased strength, you put more tension through that tissue, which you can improve with things like therapy to improve the strength and control of the femur or your thigh bone so that that pain can be dissipated.
Usually, people will present with very specific symptoms with runner's syndrome. Let's talk about those symptoms. What do you see in your practice?
So what people tend to complain of is lateral knee pain or outside of the knee pain, predominantly with running. Can be worse with downhill running, or even cyclists who have a repetitive pedal stroke can get outside of the knee pain.
I've often found in diagnosing this is runners will say, well, I start off and I feel pretty good, and about mile 2 or mile 3 or whatever it is, somewhere in this run, they start experiencing these symptoms, which is pain, burning pain right at that point. Why does that happen? Just overuse and that chronic rubbing of that tendon?
Exactly. It tends to be when our muscles get tired or fatigued, then you get more tension through that area, which can put friction through the area, which is also called iliotibial band friction syndrome. And then it goes away when you rest. So it's really happens when you're doing the activity.
And the activity is not just running, it's cycling, but also sometimes just people that do, you mentioned repetitive flexion extension or bending and straightening your knee, where mechanically you're taking that tissue and rubbing it over that condyle or that bony prominence.
Exactly.
And how do you diagnose this? What is the best form of diagnosis that you have found in your practice?
The best form of diagnosis is a detailed musculoskeletal examination. So that gives us the majority of the information that we need to treat the condition. However, sometimes you can use things like diagnostic ultrasound to evaluate for swelling or thickening of the tissue in the area, or even MRI.
And when you look at an MRI or a diagnostic ultrasound, from a tissue standpoint, what are you going to see on that ultrasound that confirms, like, yeah, this tissue or this tendon, because it's a piece of fibrous tissue that is called a tendon, it's inflamed. What do you see?
So you can see swelling around the area or edema in the area. a lot of times you don't see anything. You don't have to see anything.
We're going to continue our conversation with Dr. Alison Putnam from Providence Medical Group talking about iliotibial band syndrome. And coming up later, Tom DeBoard, the CEO of Overlake Medical Center and Clinics, talks about Project Future Care, something I think you'll be very interested to hear more about. That's coming up after we continue after this time out on KOMO.
It's a Northwest Lifestyle Weekend on KOMO News. Here's Tom Hutler and Shannon O'Kelly with more IRG Health Talk.
We continue our conversation with Dr. Alison Putnam and Shannon O'Kelly.
Thank you again for coming down and joining us here on our radio program, and particularly talking about iliotibial band syndrome or IT band tendonitis. You described it, set it up nicely. We've diagnosed it. Now, how do we treat it?
Typically, physical therapy is the best treatment option that we have. We work on strengthening of the core and the pelvic muscles and the hip girdle, and that can treat the pain at the outside of the knee. Doesn't make a lot of sense to most people, but it works really well. It's
a very mechanical condition. From a physical therapy standpoint, you have to look at the mechanics. You described the core. You have to look at flexibility. You have to look at strength. But biomechanically also, sometimes we look at the shoe and we look at the feet, because if it's pronation or supination, there's a lot of different activity at the feet. It can affect how the IT band is wear and tear on that condyle.
Exactly. At the feet and the knee, the way the tibia or the shin bone rotates, the way the foot pronates or inverts as you run, all that can impact the pain at the outside of the knee.
Tell us the next step if conservative care is not really effective.
Yeah, we try to use anti-inflammatory medications in the beginning when you do have some inflammation there. We try to avoid those when we don't think there's inflammation and it's more of a biomechanical diagnosis. There are injections. We really only do steroid injections if there is evidence of swelling there, because you don't want to damage the surrounding tissue.
And tell us about those injections, because I mean, in my experience, patients are awfully confused about what is a steroid injection. I'm getting a cortisone injection. Is that an epidural? Is it something that's going to, what is it going to do? So I think there's some confusion about injections. Maybe talk about injections.
So cortisone or steroid is the same thing. It's a corticosteroid. So what that is an anti-inflammatory medication. So if there's not inflammation there, it's really not going to help the condition. So that's why it's really only useful if there's actually swelling in the area.
And so what you're trying to do is you're trying to inject that steroid into that inflamed area, giving your body kind of the uptick of an anti-inflammatory procedure or process.
Exactly. Yeah, to reduce the swelling that we think would be contributing to the pain.
And people often ask, if I have it on my right side, am I going to get this on my left side? I've not seen that a lot, but people ask, and sometimes maybe a year later you might see that same patient that comes in with the left side, so you have to work on your mechanics.
Exactly. Working on your form during your activity that's bothering you, whether that be running, cycling, dancing, whatever it is that bugs you, is the most important, so that you can prevent it from recurring.
I personally have never seen anybody that needs any kind of surgical intervention. Have you?
I have not seen anyone who's required surgery. That is typically the method of treatment that is the last resort for anyone.
Right, yeah. One of the things that you probably look at and we look at in physical therapy is really, again, the foot mechanics, and we might suggest a different shoe wear or changing shoes. I know I've seen it where people sometimes go out and do too much, too fast, too soon, and it really is one of these overuse, kind of repetitive trauma type situations.
Yeah, it's definitely overtraining, over mileage, change in striding, sprinting potentially, though sprinting a little bit less common, or even hill training and wearing old shoes that can have less shock absorption. Yeah,
and people don't realize your shoes are really only good if you're an active runner. I think they're only good for 3,000 miles. I'm not sure what it is.
250 miles.
Okay, there you go. I'm glad you said that. See, I brought that up.
Or 6 months.
Yeah, good. Well, I'm glad you brought that up. I was over on that a little bit, but all those things to look at are important. Well, once again, thank you for your time. Thank you for information, Dr. Putnam.
Yeah, thank you.
That's been Dr. Alison Putnam from Providence Medical Group's Everett Physiatry Board, talking about the iliotibial band syndrome, and good to hear about that stuff. And you guys obviously know what you're doing when it comes to these kind of solutions. But Dr. Putnam has more information if you'd like to get it at providence.org. Our next guest is going to be Tom DeBoard from Overlake Medical Center right after we take this time out on KOMO.